the CT angio or the MR angio are very important because it's on those modalities that we can find patients who have a clot in a vessel that is reachable by the interventional doctor and potentially can be retrieved. So without having those, we really don't know where the clot is. And that's why, as I mentioned, many and probably most centers now do some form of angio as part of the initial imaging. Now, where it gets a little controversial is how much should you spend time on identifying the extent of the ischemic core and the extent of the ischemic penumbra. I would say within the first several hours after stroke onset, it probably is not needed in most situations because if you have a proximal vessel occlusion and it's 3 to 4.5 hours or so after stroke onset, the vast majority of patients are going to have substantial amounts of penumbra or potentially salvageable tissue. On the other hand, to add in the CT perfusion imaging, if it can be done quickly within a couple of minutes and processed, you're not really wasting a whole lot of time and you do have additional information. So in our center, we do it typically because it doesn't take much extra time and we can get it processed quickly on our software package called Rapid. There are other colleagues that really don't think it's necessary up to 6 hours after onset, but I encourage centers to do it if they can do it quickly and they have one of the processing softwares available to them, which literally takes a minute or so to give you the extent of the ischemic core and penumbra. Now, when we're talking about patients beyond 6 hours, the clinical trials, DEFUSE 3 and DAWN, use advanced imaging, i.e. imaging to identify the extent of core and penumbra to select patients. And it makes sense because the further that you get out from stroke onset, on average, the larger the core is going to be because it evolves over time. Now, what we've learned over the last couple of years is that the timing for the evolution of the core growth is quite variable among individual patients. And it's literally impossible to predict how fast the core is evolving from clinical parameters. Now, on plain CT, there is an approach that's used called the aspect score, which looks at the extent of hypodensity on several slices on plain CT. But there are problems with the aspect score. One is it's not so easy to do, and the inter-rater reliability is not good. Another problem is that, for example, an aspect score of 5 on a 10-point scale can mean different things because if the hypodensity is primarily in the basal ganglia as opposed to the cortex, then the actual volume of the core would be much smaller. And so an aspect score of 5 might actually be associated with quite different core volumes, which would have different implications as far as response to treatment. So I would encourage centers to, if they're doing CT, to do CT perfusion and to acquire the modality and analyze it as quickly as possible. And if they do MR, same thing, I would add on MR perfusion if possible. And it also needs to be processed quickly so that the results become available. So that's a short overview of basically what I present in the lecture.